Sitting down. I think it's a 2-hour thing that we'll do, but we'll give you a little break in between. I did this last year, and hopefully it will help you. It's just a lot of pictures, and we'll go over a few things that are common that you'll probably experience in your practice, especially if you're going into primary care types of specialties. All right. I have no conflicts of interest relative to this presentation. We're hoping to identify some common dermatologic disorders, looking at their morphologic features, which basically mean morphology, means what it looks like clinically, and using diagnostic tools. Also discriminate clinically between dermatologic lookalikes. What are some features of each that will help you distinguish between them? And also review treatment modalities for common skin diseases, costs, dosings, side effects, those kinds of things. Okay, so acne. That's one of the biggest things that you're going to be seeing in your practice. It is the most common skin disorder in the U.S. and usually around puberty. And I mean, we're seeing it at 9 and 10 years of age, acne. And it can be very devastating for young prepubertal kids, especially if their parents have had acne. It definitely makes the kids more prone to acne genetically. And there's 4 main pathophysiologic factors of why a person gets acne. Or I'll say those later, but there's 4 things that happens in acne to make it develop. One of them is follicular plugging. So as you know, acne forms around hair follicles, and the opening or the os, the follicular os, gets plugged with keratin. And so that's one of the initial things that will happen. Dead skin over the surface, as well as the inner lining of the hair follicle is keratin produced and will clog the pore there, and that's what blackheads and whiteheads, and that's the early development of acne. Oil, so as in puberty, hormones are changing, it's testosterone. Girls and guys both have testosterone. Girls or guys have about 10 times more, so that's why guys usually have worse acne than girls, but it's that testosterone that activates the oil glands, makes you feel greasy and oily, and even into the scalp hairline. But that is a process, part of the acne issue. And then there's bacteria associated with acne. It's called Propionibacterium acnes. We say P. acnes, but that is there, as well as inflammatory cells and cytokines. And so we'll talk a little bit about those things, but all of that comes, and what happens is, as acne is developing, you have this, the epidermis, the stratum corneum, which is the top layer, the very little thin 1-layer black layer is called the stratum granulosum, and then all of this pink layer here, stratum spinosum, and then the very 1 layer at the very bottom of the epidermis is stratum basalis. Those underlying layers are contiguous with the hair follicle. And so this inner lining of the hair follicle makes the keratin, and you get this little plugging. And at the same time, you've got this gland over here, which is the oil gland attached to the side wall of the hair follicle. And during puberty, testosterone is the big one. That androgen is just going to trigger the production of oil, and it flows through the tubular central portion of the hair follicle. But if it's plugged at the top with keratin, that keratin protein is like a cork in that opening. The oil cannot get out, and so it has nowhere to go, and it continues to build up big, huge. The oil gland does not know when to shut off. It just is producing because of the trigger of the hormone. And so what happens is, initially you have what's called a closed comedone, where little bit of epidermis, and that keratin is right there. And so that's what a whitehead is. Over time, the opening actually widens, and you get more of that dead skin keratin stuffed in there, and it becomes dark. And it's not dirt that makes it dark, it's melanin. So you get melanized keratin in that opening, and that's what people call blackheads, okay? Or we call them open comedones, and it's just the melanin that has clogged or has incorporated into the keratin cheesy material. And so that has happened. This over here is basically showing you again the androgen or testosterone triggering the oil gland and how it kind of dumps into the shaft of the hair follicle. And that also can come out to the surface, and that's what makes people feel shiny and greasy. So you know that you have excess seborrhea. Seborrhea is just the other word for oil. And then the hyperkeratosis, that means keratin crust excess at the opening there, clogging. And then over time, you see the whole hair follicle turns into kind of like a balloon because the oil gland is just continuing to produce, and it's like a balloon that ruptures, and all of the little bit of oil will leak out under the surface of the skin within the dermis and cause an inflammatory reaction. So this is what that purple ring is showing you of inflammation cells coming, pus, neutrophils are coming there, and then when all that happens, bacteria is there to eat up all the debris and the ruptured hair follicle, and that's where the red inflammatory tender lesions of acne are coming from. So if a person has red tender inflammatory papular or nodular acne, then we already know that the hair follicle ruptured, bacteria is there, oil has leaked, and this, whole process has happened. So for that, of course, you just can't deal with a little topical, you have to start thinking about systemic things. So acne is based on clinical morphology, the treatment of it is. So if a person, do you see the blackheads there? Those are the open comedones. They're a little, the opening is dilated more. You see the keratin that has been melanized. And so if a person has just prominent open comedones, treatment, you have to think of certain things. Closed comedones are basically the same thing, but just a little epidermal layer over it, so it didn't get oxidized to the air and melanin didn't come there. So usually blackheads and whiteheads, as we call them, are treated similarly, and we'll talk about that. Here is mixed comedonal, where you have a little bit of both, and actually in the midst of it, there's a pustule. So don't get the pustules mixed up with a whitehead. These are considered non-inflammatory. The comedonal stages are considered non-inflammatory. It's just stuffed with dead skin. So that means there's no redness usually associated with it. There's no inflammation. So here you're starting to get a little pustule, and even down here in your papules and pustules, you're getting all this inflammation surrounding each lesion. So that's where the bacteria stage becomes. And then of course the nodules and cystic lesions, that's where, you're developing maybe two acne lesions coming together and developing a huger nodule. And especially in people of color, you have to be mindful that pigmented skin is very labile. In other words, the pigment cells in people of color get disturbed easily. So when there's inflammation or some sort of trauma, the pigment cells in the area tend to either shut down or rev up. So with people of color, acne usually has hyperpigmentation, post-inflammatory hyperpigmentation. So in acne, usually you see a lot of dark spots with their acne. And so many times when they come to your office, it's not so much the inflammatory pimples that they're so concerned about. It's like, how am I gonna get rid of these dark spots? What do I do? That's their biggest concern. So, of course, you gotta treat the main issue and calm the inflammation down, which triggers the melanocytes to extrude their melanin. And then you have all the melanin in the dermis getting eaten up by histiocytes, and they call them melanophages. So melanophages are macrophages that have eaten the melanin that has been extruded, and so you see those deposited in the dermis, and it can take a long time for that to finally fade out. So many times with people of color, not only do we give them the antibiotics and retinoids and things of that nature, but we give them a fading cream or something to help lighten up the process. And again, in people of color and those who use a lot of hair gels or hair greases or oils in their hair, those products, especially if they're applied close to the hairline, if you sweat and all, that can bleed down into the forehead and plug up into those openings of the hair follicles and cause what we call pomade acne, which basically is plugged pores, but that the product in and of itself is now plugging in those pores. And it's very distinct because the acne is only here, not on the cheeks or chest or anywhere else. So you know it's up here. So you can't just say, okay, you got to stop using everything that you've been doing on a daily basis for your hair care regimen. We just tell them to at least a couple of centimeters be behind, or about an inch behind. Then that's where you can start putting your oils or ointments or gels. Do not put it at the very edge. And to not use products that are oil-based or mineral oil-based. So petrolatum is Vaseline. So some of them are heavy, thick Vaseline-based greases. That's all going to clog the pores, and all that oil underneath is going to build up, burst like a balloon. So you want to use water-based products for the scalp, and they make those that are for hair dressings and things that are water-based or silicone-based or glycerin-based. So you can give them options. If you take something away, you have to give them options so they can continue their hair regimen. So let's look at some treatments. And so it's based on pathogenic factors, how bad it is, the grading of it, and that's like, is it just a little open comedones only, or are we looking more into inflammatory stuff, or are we looking into scarring, nodules, cystic? Grade it. And then how severe is it? Widespread, or is it just only in the T-zone region? Sorry. So overview of acne. So we talk about mainly topicals and oral. Topicals and orals. And so for the low grades, and that means the whiteheads and blackhead stage, maybe a few little pustules that are starting to develop, which is basically neutrophils or pus that is just early starting to develop along over the hair follicle. We can use topicals only. And so even over the counter, if a person's not ready to have prescriptive things, benzoyl peroxide is out there. And it's over the counter in multiple forms, but it's both antibacterial, we'll talk about it, and it's keratolytic. And what's that big word? Keratins, that protein. Lytic means lyse, so it's going to break down the keratin, and that's great for the comedones. That's what we really want. We want to clean that plug out. So it has both antibacterial and keratolytic effect, which is great. And they make combo things. I didn't put all the brand names down here, but just know that there's a lot of combination topicals these days. So they put together benzoyl peroxide and clindamycin together. They put together benzoyl peroxide and erythromycin together. And that's a good thing because clindamycin and erythromycin on their own they have high resistance. They may work for a tad and then they stop working. And so, and erythromycin even worse than clindamycin, so we don't even really use erythromycin topically much these days. So benzoyl peroxide reduces resistance of those other antibiotic combos, so it's helpful. Dapsone is topical now, it's sulfa-based. Adapalene, tretinoin, and the tazarotines are what we call retinoids. Those are all Retin-A products, and Retin-A is vitamin A, and we'll talk a little bit more about that. But topically, it acts like a chemical peeler. It is a keratolytic agent, just like a portion of benzoyl peroxide. Adapalene is also known as, if you ever know it, Differin. It's now over the counter. It's the mildest of the retinoids. And so I think the lowest potency of it is a 0.1%. So they have now placed it over the counter. So it really only works for very mild disease, but it might be a good place to start for someone very young that's just barely getting their blackheads and whiteheads and a little bit of oiliness. So that's over the counter. And of course they have combos with benzoyl peroxide too. Tretinoin is kind of the mid-potency Retin-A product, and there's combos. Tazarotene is the most effective of all of the retinoids. It can be very peeling, but those who are very oily can take it. And so we use it mainly for comedonal type of acne. Salicylic acid is over the counter too. You can find it in washes. You've seen it in Neutrogena, the orange gels and things. And so it is also a chemical peeler, may help to peel a little bit and cut a little bit of the oil. It's not antibiotic though, but can be part of the process. Azelaic acid it comes in foams and creams. It's a prescription. We use it more for fading. It's not a great acne anti-inflammatory, but it's a great one for fading purposes and lightening up dark spots. So we can use it for that. Let's move over to the oral. So when you start thinking about using pills, then you're seeing inflammatory papules, nodular changes, that kind of thing. Maybe not only the face, but now it's including the chest, back, and shoulders, more extensive in the severity. So our oral antibiotics, know that tetracycline family, we say that, but in and of itself, tetracycline is no longer available. There's been a shortage, I guess, of its ingredients, so you can't get it anymore. You can't write for tetracycline. But you can write for its cousin, minocycline and doxycycline, and we use those a lot for the oral antibiotics in acne. We also will use sometimes the sulfa-based antibiotic, trimethoprim sulfamethoxazole, also known as Septra or Bactrim. Sometimes we'll use that. And then, probably not a first-line agent, but Dapsone is also oral, and it's a sulfa-based antibiotic, and it can be used. There's other combos that have been shown to be helpful in acne and some of other nodular cystic things. Clindamycin orally together with rifampin. Sometimes we'll just potentially use it as a, second line or third line choice. For your oral retinoids, that's what isotretinoin, also known as Accutane, and that that actual brand Accutane is not available. They make so many different generics of isotretinoin now, and it kind of is based on what your insurance will pay for. But isotretinoin it's been around since the 1980s, has changed the way we treat the most severe kind of acne. It is FDA approved for nodular cystic acne, scarring acne, acne that's causing psychological issues and depression, and acne that's just not getting clear with regular classic medicine. So we'll talk about that. And then especially for our females, many times acne gets worse around period time, hormonal changes, menstrual cycle. And we also see a surge in adult female acne. Maybe when their estrogen level is slowly reducing, there's nothing to balance out the androgen, testosterone. So a lot of women who either have had a hysterectomy and their ovaries are taken, which is their major source of estrogen, and it's gone. It has there's nothing to combat or balance out the testosterone that they still have that's being produced from their adrenal glands. Or maybe they've gone through just, natural menopause. Or they have what's called polycystic ovarian syndrome. Have you heard of that? Where you really have potential excess of testosterone. All of those can lead to acne, especially in the bearded region. So that's more of a hormonal type of acne when, especially females are getting acne more in the bearded region. They don't have it on the chest and back so much. And they may even start getting a little hair growth of the chin or upper lip area. And that's testosterone majorly driven. So we may use our hormonal treatments to combat that. So topical antibiotics, we'll get more into it. We just said it's active against the bacteria part of acne. It is anti-inflammatory. And that really should say it's anti-inflammatory. They're not comedolatic. So in other words, that means they will not lyse the comedones, the keratin. So antibiotics are more against the bacteria, and we just talked about the erythromycin, clindamycin, sulfur, and the bacterial resistance, especially with erythromycin. So BPO is just another little abbreviation we use for benzoyl peroxide, which lessens the resistance of those other antibiotics there. These are just showing combinations of those types of products that we have. So benzoyl peroxide, though, has a little bit of both antibacterial and comedolytic or keratolytic. And so it's great for just the topical, mild type of acne that's mild to moderate. There's no bacterial resistance with this using it alone. So it's over the counter. A lot of people can just start trying that. It can be a little irritating. It can be a little drying. Some people get red with it. So it does come in different concentrations. As you know, Proactive, it's a 2.5%. You can find all the way up to 10% with Panoxyl. That one's over the counter, and bar soaps, foamy cleansers and gels. And literature shows that the concentration really doesn't matter. It's not like you have increased efficacy with the 10% versus the 2.5, but it does, the 10% has a little more activity against the oil and that type of thing. So if you need that, you might get the higher strength. And if you've ever used benzoyl peroxide yourself, it bleaches. It will leave white spots on your clothing, on washcloths. You must warn the patient. Let them know that. So I only really, unless they have it just of the face and it's in the combo with a different gel, another antibiotic or retinoid, that's great if they're just using it for the face. But if they have acne on the chest and back and you're thinking you want to put benzoyl peroxide in a gel or whatever all over their back and chest, and then they put a dark t-shirt on, they're going to get white spots and bleach their whole clothing. So I tend to just use it, if they do have it on their chest and back, as a wash. So as a cleanser, and use it in the shower every day. So if I give them instructions, I tell them to lather it to their acne daily in the shower. And there's, as I said, cleansing foams over the counter that can be used really nicely. And that's a great type of product for the back and chest involvement. Retinoids, Retin-A, we know that is also lysing keratin. It also has some anti-inflammatory properties. It doesn't really do anything for the bacteria though. This is a vitamin A derivative. And we know that adapalene, that's that different over-the-counter, the mild form of it. Tretinoin and tazarotene are all retinoids. If you are dealing with a lot of Sooner Care or Medicaid patients, tazarotene at the moment is the only one that's Medicaid approved. So we do use that one a lot, write a lot of that for our Sooner Care patients. And again, many times people just will use it in combination, and we like to use our retinoids at night because a lot of times if you're using it in the day and you're outside, vitamin A is sun sensitive. And we'll talk about that with isotretinoin because it's oral retinoid. It's truly sun sensitive, but even the topical form, if you're out long enough, you're going to get red. It may start to get to peel a little bit. So we just say use it, apply it thinly at night over the face. And avoid irritating regimens because it can make your skin chapped and peel because it can also shrink a little bit of the oil glands. We do know that. So you don't use Clarisonic. Sometimes people forget to tell us what they're using on their just regular regimen. If they're using witch hazel or some sort of toner, you can't use retinoids or even benzoyl peroxide for that product. If you're using all those things, you'll be too irritated, and then people come back and say, I'm allergic to this. I'm like, no, it's just you're putting too many things together, you're getting yourself irritated. So we try to use gentle cleansers and moisturizers with retinoids. Again, there's combos that have retinoids in them. Let's look at our oral antibiotics. As you know, it's reducing that Propionibacterium acne or P. acne within the follicle and surrounding tissue. And it's for those who are getting a lot of the inflammatory papules, pustules, nodular changes, doxycycline, minocycline, the sulfa-trimethoprim sulfamethoxazole. What are some of the things you have to think about with these antibiotics adversely that you have to, talk to your patients about? A lot of them will cause upset stomach. So I know in the past when tetracycline was around, the pharmacists in their handout would say, do not take with food, don't take on an empty stomach, you can drink with water, do not take with calcium products. But you can, especially with doxycycline, well, all of them, take with food, take them with food, it's really okay. And it's okay to take them with dairy products, these doxy and minocycline. Doxycycline especially, you do not want to lay down immediately, at least for a good 30 minutes after you have taken it will cause gastric reflux. So you must stay upright for the first 30 minutes after ingestion with doxycycline there, okay? Photosensitivity, doxycycline is the worst with that. Although we use it a lot, we just warn patients, because we've got teenagers that are out there, football and cheerleading and all of this. We ask them to wear their sunscreen, and it's best, just as a plug for sunscreen. We like SPF 50 or higher, and we like the physical blockers in sunscreen, and that is what zinc and titanium ingredients are. They are physical blockers. They will block both UVA and B coming through the skin, so they really impede the penetration of UVA and B, and they're non-irritating. So if you look at baby sunscreens, they have zinc and titanium. There are chemical blockers that you can find. Those are the ones that don't have the zinc and titanium, and they're found in all different products. But many times those are the ones that burn your eyes, and you have sensitivities to them, especially of the face. So you get ones that are zinc and titanium, and they tend to hold up better anyway. They don't break down in the sun like the chemical blockers do. So overall, we like our zinc and titanium, and there are ones, and people think, oh, I don't want to use it because it makes you pasty white, the zinc and the titanium. But they now make them invisible. So there's brands out there, just look, visible zinc, and you can use them. Minocycline, in addition, can give you headaches, a little bit of dizziness. This is not in all patients, but we tell patients, hey, this is potential, it can happen. And we know that it can cause some hyperpigmentation, if you're using it for longer, many, many months. So we warn them. And sometimes with the dizziness and headache issue, you take these at bedtime, if it's only a nighttime dose, that usually wears off and, they sleep it off. And of course, with Bactrim, that's the sulfa medication. It can be very helpful, but you've got to warn them about potential allergic reactions with Stevens-Johnson syndrome, the toxic epidermolysis necrolysis, epidermal necrosis, and photosensitivity are also issues. Let's go to the main medicine for nodulocystic and scarring acne, and isotretinoin, which is systemic retinoid, approved for the severe recalcitrant nodulocystic acne. It does many things. So once you get on that, you really don't need any other medicines. You don't need oral antibiotics. You don't need topical product. This is it. It does a lot of things. Kind of does it all. Normalizes the epidermal differentiation. It's anti-inflammatory. It's active against the P. acne, so the bacteria is reduced. It suppresses the oil or sebum production. It does it all in one. And though it can be very expensive, I've seen $250 a month or $300. In its early stages, it was like $500 a month. But that is if you're paying for it out of pocket. But you can, most of the insurances will fund it. You may have a copay of $30 or $40 or $50. And of course, there are mail order pharmacies that contain it, that, like your RX pharmacy, that you might have the ability to get a lot cheaper. But orally or systemically, isotretinoin is teratogenic. It causes hydrocephaly. It causes limb defects. If a female was ever pregnant and even taking one tablet of it while they were pregnant, it can cause these potential teratogenic effects. It also can give pulmonary, lung, heart defects. It's horrendous birth defects. So there is extensive contraception counseling that we give to our females especially. With that, and they have to be on, especially those of childbearing age, they must be on 2 forms of birth control. One has to be either hormone, or maybe if it's an adult, their partner has had a vasectomy, and that counts for their primary birth control, or maybe they themselves, they've had a tubal ligation, but those aren't 100% proved, so they have to be on a backup method, which is either a condom or foam or some sort of barrier method. We will accept abstinence. The program will accept it. If we see that the patient seems to be committed and will be consistent, we will do that as well. But you have to get enrolled in the iPledge program. Doctors or any PAs who are going to prescribe this, they have to participate in the iPledge program and become registered. Providers or prescribers, pharmacists who give it out and dispense it, they have to be registered with the program. There are some pharmacists that do not participate. And the patient has to be enrolled in it. So it's kind of a lot of hoops to go through, but for those patients who really need it, it is a lifesaver for them. But if you've taken any nutrition courses, vitamin A, which is this retinoid, is fat soluble, so it doesn't make you fat, but you can potentially elevate your triglycerides, cholesterol level. It also gets metabolized in the liver, so we're looking at liver function. Sometimes this medicine can potentially lower white count, very rare, so we get a CBC for that. And of course, for all our females of childbearing age, they must have 2 urine pregnancy tests negative, and they have to be a month apart. So that means if I'm counseling a female on the very first day, they can't get their medicine that day. They are enrolled, and they get their first urine pregnancy test, they come back to me in a month. And if their second pregnancy test is negative, then the program will allow me to give the medicine. For men, there are slight levels within the semen, so they do state, you need to be wearing condoms if you are the one getting treated with isotretinoin. But the good thing about it is, this has a very short half-life. Although it has wonderful long-term benefits on the skin, it only lasts about 30 days. It takes 30 days for it to metabolize out in the bloodstream. So that's good. And so the thing is, that doesn't mean you can just start a family right away after that. They want you to wait several months after it anyway. Even if you wanted to donate blood, you cannot donate blood for at least 6 months to a year. There are guidelines on that. But there have been reports of mood changes, depression, but there have been so many repeated, independent, prospective, double-blinded studies, especially in teenagers who we know are at the higher risk for depression and suicide. They have taken groups of them, divided them up. Some are on the isotretinoin, some are on topical treatment for their acne, and following them through 4 to 5 months. And they actually found that it was the isotretinoin group that actually their mood improved as they saw their skin clearing up. And both of these groups, the control group and the treated group, had the same severity of acne. The group that just had the topical treatment that had nodulocystic disease, their depression and scores and quality of life scores were worse as they did not see their skin clearing up. And so, to date, there has not been shown a direct link to isotretinoin and suicidal issues. But if there is a patient that has history of depression or on antidepressants or antipsychotics, we are a little more cautious. We want approval from their psychiatrist that they are on board with this, and we'll just be very cautious in those patients. It is, if a person is coming off of antibiotics and wanting to start Accutane, if the antibiotics aren't working, and they have been on minocycline or the doxycycline, you have to give a washout period of 1 to 2 weeks or so. Why? Because in close combination or using those medicines at the same time as isotretinoin, it causes this down below, pseudotumor cerebri. They're going to have horrendous headaches. And they're going to have this little bit of swelling that happens. So that's one thing that we do avoid. So this just is talking about the updated guidelines of our academy. The American Academy of Dermatology published in the journal in 2016 the acne guidelines. No studies to suggest an evidence-based link between isotretinoin and depression, anxiety, mood changes, or suicidal or suicide exists. Multiple studies have shown no evidence of depression from isotretinoin on a population basis, and that's saying we already know there's an amount of depression in teenagers nationally. They're just saying that there was not an increase amount within the isotretinoin group. There was probably some depression in that group, but it was not increased over the national rates. On the contrary, most studies have shown isotretinoin to improve or have no negative effects on the mood and memory or attention or executive function. Given the prevalence, though, of depression, anxiety, and the suicide issues, the physician or provider should continue to monitor for these symptoms. So every month, this is a medicine that they only get a month's supply at a time, and usually it's an average of 5 months or so that they're on the medicine. And so we still ask, have you had any mood depression, any anger outbursts,
And I asked for GI upset, because they can't give you that a little bit. Dry lips is the huge, biggest issue because it's shrinking oil glands like crazy. And you can get dry lips. Those with contacts may need re-wetting solutions. Moisturization of their skin has to occur, all of that. Okay, this is hard to read, but this is also talking about, there were some big issues. Does this cause ulcerative colitis and any inflammatory bowel disease? Well, they looked at over 40,000 patients, and basically, this was a French study, and the conclusion of this study, some of it is evidence is insufficient to prove either an association or causal relationship between isotretinoin use and inflammatory bowel disease. So they've kind of looked at that issue too. Now let's go to some hormonal things. Actually, this one's not a hormone, spironolactone. You all have heard about this, right? A lot of adult women are on spironolactone for their hormonal acne. It is not a hormone, it's a diuretic, right? But it binds androgen receptors, so this chemical will attach to the receptors of androgen receptors so that testosterone can't bind to it. And there's androgen receptors all over hair follicles and oil glands. And so it helps to reduce the androgen production, suppresses sebum production, and especially used in adult females. And we use it in lower doses, usually somewhere between 25 to 100 milligrams daily. I've used 200 milligrams daily too. But in comparison, when primary care docs and providers are using it for blood pressure control or for true diuresis of, bilateral edema or maybe congestive or liver ascites or things of that nature, it's in the 300 and 400 milligram range daily. So these lower doses usually do not cause hypotension or dizziness or any issues of that in these low doses, but we do ask about it. We don't want a female to get pregnant with it because it's not good to block that androgen if you're having a male fetus developing. We do check blood pressure in our office each time a person comes for that. But interestingly enough, there's been studies on, okay, do we have to get routine labs on this medicine all the time? Out of Brigham and Women's Hospital, they showed that routine potassium monitoring it's not recommended, it's not cost effective at these lower doses, and so you don't have to. Unless a patient has concomitant diseases that may have, variation of potassium levels, maybe renal issue or something. So, but it's very helpful. It is not a hormone in of itself, but it really helps to control oil, the greasiness of the face, and those tender nodules and papules along the jawline in this bearded region. So think about it when it's just that pattern alone in an adult woman. And it's nice. It's not an antibiotic, so they're not going to build up resistance. It's not a true hormone, so it's not like putting them on birth control. Oral contraceptives, a lot of people want to say, okay, we just need to put you on a birth control pill. Well, for acne, we don't use it alone for acne. It's considered adjunctive therapy, so there may be some topical medicine that might be used because it is reducing androgens, especially, and it's the combo medicine. It's the estrogen and progesterone combos that you want to look for. Monophasic. Do not prescribe multiphasic, because you're not wanting them to go up and down throughout the month and having issues. And actually we had one of our leaders in OBGYN who gave us a lecture in dermatology on polycystic ovarian syndrome, but also just on contraceptives. How do you choose? And she said, I'm not really sure why multiphasic birth controls were made. Nobody wants to go up and down. They want to be steady. throughout the month, and so they don't have breakthrough bleeding and symptoms and things of that nature. So she said there's no real major reason to be prescribing a multiphasic contraceptive. So your monophasic ones are good. And so the FDA approved birth control pills that are for acne, Yaz, Diaz, orthotricycline, Estrostep. But there's so many, and all of them could, these monophasic ones that are both estrogen and progesterone combo. You do not want a progesterone only birth control. The progesterone only will then potentially give you acne. The Mirena IUD, it is progesterone only. So we've seen women who start to develop their little acne along the bearded region on that as well. Norplant, what's the 3-month shot? Depo-Provera, ooh, that really can increase acne too. It's progesterone. So even though it's convenient, there may be other things. So interestingly enough, we just talked about spironolactone, and there are certain contraceptives that have analogs of spironolactone. Yaz, Biaz, and the analog is drospirenone. And you'll see those in the ingredients when you look at those. But it is structurally related to spironolactone. So it also, in and of itself, that medicine will help to reduce the testosterone with that chemical structure. And it only, though, has about 25 milligrams of spironolactone activity in those contraceptives. So I tend to like to use the spironolactone ingredient alone so I can titrate up the medicine if need be. Contraceptives, you have to be careful. You want to avoid in high-risk patients, as you know, who for prone DVTs, strokes, breast cancer, liver disease. Monitor patients with hypertension, obesity, seizures, all those things. Some patients get a little swelling, bloating, hair loss at times. All right, we're going to look at now that we just talked all about acne, we're going to look at acne rosacea. Some people just say rosacea, but some people get it confused. And rosacea is an adult disease, okay? And it's central face, usually in fair-skinned Caucasians. It doesn't occur on the chest, shoulders, and back like regular acne. It is a facial disease, okay? But it can have overlap papules, pustules, and nodules. One thing it also has, you see these little telangiectasias, little blood vessels. That's a common thing within it too. But, so central disease, and it can just be red patches of redness that you start to see a little bit, a higher stage with pustules starting to develop. And notice that there's a little lightening here in the creases, the nasolabial folds, and there's lightening around the eyes here. And that's because this is a photosensitive disease. Sunlight makes it worse. So on the face where there are folds, those are considered shaded regions. So, or sunken areas, they're kind of shaded, so the redness doesn't occur in those areas, okay? So flushing, blushing, telangiectasias, you can get red papules, pustules, nodules, but no comedones. So rosacea classically has no blackheads and whiteheads. It is not part of the disease, okay? What is rhinophyma? Well, if you've heard about W.C. Fields, Bill Clinton, there's a lot of people that have rhinophyma. And that is I might show you on another page, but it's the thickening, glandular, oily change of the nose that it distorts the normal shape of the nose. And that is a stage of rosacea. Pills and creams do not help with that. That has to be resurfaced away and blasted away with laser resurfacing. And then there's an ocular type. So rosacea can also enter into the eyes and really make the conjunctiva inflamed and red. So here we are. Some people just have the red patchy stage where it's just red and flushed with blood vessels. Then you get the papular stage, papules and pustules, maybe a few nodules, and look at this rhinophyma. You've seen people with that. And that is all heaped up sebaceous hyperplasia, thickening of the oil glands. There's no cream or pill that will get rid of that once it happens. And I've had many, usually men get this more so, and it can be very embarrassing and yeah, where they want to stay out of the public eye. Look how red and injected the conjunctiva. So we look at the eyelids, and that's a reason to utilize oral medication. We know rosacea usually is in females, mid-age there, Celtic or Nordic descent. Some people have a little acne together, so if you're seeing that in their flesh, but then they might have a few pimples here and there, they have a coexistence of the two. They're not systemically ill though, because some people say, oh, the red rosy cheeks, the butterfly rash of lupus. And so sometimes in females, that has to be considered. But if they're not sick, they don't have arthritis and some of the issues with lupus, then not likely. You might think about asking them triggers. Does sun make it worse? Alcoholic beverages that dilates blood vessels, so you're flushing and not flushing. Anything that dilates blood vessels. Spicy foods, hot beverages. So if you're drinking lots of coffee, hot tea, it flushes your skin. If they're exerting themselves physically or getting in saunas a lot, they're going to get red. Stress will do it as well. So there are topical things when it's mild that can be used, and usually it's topical metronidazole is the biggest one that's used. Topical metronidazole, also known as Metrogel, Metrolotion. And interestingly enough, to date, there's Metro gels that are used for vaginal bacteriosis. It is the cheapest form if a person didn't have insurance. And so many times we'll write for it, but you have to say vaginal, metronidazole vaginal, and you have to warn the patient, yes, it's the same medicine, it's okay to use it on your face, don't worry. You know, sometimes it's hard to convince a male, but you know, it's the same thing. Azelaic acid, we talked about that in acne. It's kind of like a medicine trying to find a disease, what to do with it. But it can be used for rosacea, it's called phenacea in brand form, but it probably works the best as a bleacher agent. Sulfa-based products can be used, and one thing we do want to avoid in rosacea is steroids. They may help to calm a little bit, but over time, if you continue to use steroids, there's going to be new blood vessels that form. Steroids topically, you develop new telangiectasias, thin the skin, make you bruise easy, and then you get used to it where you don't want to get off of it. And if you stop it, after using it a long time, people develop what they call tachyphylaxis. And that means their skin just rebounds really bad with the redness. And like, I can't be without it, I gotta get back on it. So it's a weird cycle. So we do not use steroids in rosacea. Orally, kind of similar to acne, doxycycline, minocycline. You can use oral metronidazole and sulfas. And if it's really bad with nodules and cystic things, we'll use our isotretinoin. Sometimes for the broken vessels, of course, the creams and the pills that won't get rid of that, we'll use lasers and light sources to close those veins. Another look-alike on the face is perioral dermatitis. And it's another acne look-alike, but it's orificial. So it's around the eyes, around the nose, around the mouth. Those are where the papules and pustules hover. And sometimes there can be little scales with it a little bit, or scabs. And I've seen some primary care providers think it's eczema and they're giving them steroids. This is another one you must avoid steroids. It makes it worse. So if you just see it hovering just little bits around the nose, or a little bits around the mouth, or eyes, think about, they call it perioral dermatitis, but it can be around other orifices. Adult females, sometimes children, we see it. We're not really sure why. We don't know if it's stress related. There have been some reports, maybe it's what people are putting in their mouths that are very high in mint. So they're saying mint flavored things, tell them to stop a lot of heavy, strong mint toothpaste and mouthwashes and dental floss that kind of comes to the sides of the mouth. But we do see it in people who also have oily skin. But antibiotics are what we use, both topically and orally, just like acne. And you want to treat beyond clearance. So they may get clear in a week or two. We tell them, keep going. Treat for about a month or two. Let's get you clear and stay clear. Sometimes they stay on the topical antibiotics or anti-inflammatories like the pimecrolimus, tacrolimus, which are non-steroid. But again, avoid the steroids in the perioral or periorificial, like some places will say, dermatitis. Okay, other red rashes. Red rashes. Okay, so when you see rings, you think ringworm, don't you? Which is also known as tinea corporis on the body. This is a bright red, scaly, so I would call this erythematous annular scaly plaque. Annular in and of itself means ring-like, so you don't have to say the word annular ring-like plaque. Annular means ring-like, and usually has that central clearing. That's what we're describing. It's a plaque because it's greater than a centimeter. Anything less than a centimeter and raised, if we feel it, it's raised, we call it a papule. And if it's less than a centimeter. Centimeter and greater, plaque. If anything is flat, less than a centimeter, what do we call it? Macule. Macule. If it's a centimeter and greater and it's flat, you can close your eyes and you don't feel a thing, that means it's just a color change. Greater than a centimeter is a patch, okay? So it's always important to remember those morphologic terms as you describe things. It's especially for dermatologists, we get consults a lot from the hospitalists, our children's hospital, the VA hospital to come see consults. And, you know, it seems to be difficult for people to really describe what they're seeing over the phone. It's just a bump on the skin. Okay. Can you give me some more information? What is it? Because sometimes we want to know a little bit because we need to know, okay, do we need to bring the biopsy bag or not? Or is it something that we can maybe talk to them about over the phone? And so knowing what the color is it elevated with the papule? Or is it flat with the macule? And the sizing, where it's located? How does it look? Is it solitary, one focal area, one focal lesion, or is it generalized over the body? Is it photodistributed, meaning is it just facial areas and maybe the top extensor surfaces of the skin? So photodistribution in the V-neck, is that happening? Or is it serpiginous? In other words, is it snake-like lesions or is it a linear lesion? We want to know all those descriptive terms. So this is, trunk and limbs is the most common place to see tinea corporis, and the dermatophyte that is the most common is Trichophyton rubrum. Trichophyton rubrum, and very common in children and veterinarians. So dermatophytes are not yeast, okay? It's under the umbrella of fungi, but dermatophytes are its own separate. It is true hyphae. Yeast are pseudo hyphae. The Trichophyton group of fungi can be found on a person, so human to human, which is anthrophilic. You can pick it up that way, skin to skin contact. Or it may be found in the soil. That's called geophilic. Or the third place, anthrophilic, geophilic, and what's the other one? Zoophilic, which is pets. So humans,
add another one to that triad, and that is fomites.